Good afternoon. My name is Dr. Clement, and today I'd like us to have a look at my response to a birth PCR that is actually positive for this baby. What sort of response is expected? It's positive for HIV. That's a birth PCR. That's what we do these days. We do a birth PCR. A PCR, first of all, it's a polymerase chain reaction. P for polymerase, C for chain, reaction, R for reaction. It is a technique, it's a molecular technique that is used. It looks at the DNA. The DNA is there are only two nucleic acids. It's the DNA, deoxyribonucleic acid, and the RNA, the ribose nucleic acid. So it looks at the DNA and it says, is there HIV there or not? Or is there anything characteristic of HIV or not? Now, if it says, yes, there is, it will test positive. The PCR will be positive. And if it is positive, then we need to know what is it that we're going to do. The first thing that we're interested in is the weight of the baby. We're interested, of course, this is birth, or the age, of course. Age. If the baby is less than 4 weeks, if the weight is just slightly greater than 2, it's between 2 and 3 kgs, then we start treating the baby. We're going to give AZT, we're going to give 3TC, we're going to give nevirapine. We're looking, this is the transmission that we're looking at. The transmission during, it's an intrauterine transmission during pregnancy. That's what will be marked by a birth PCR. And a positive birth PCR is saying that the transmission took place when the mother was pregnant with this baby. So the transmission it's what is known as vertical transmission from the mother to the baby, or to the fetus when she was still inside. So we have an attack. We have an attack. We look at anyone who's less than 4 weeks, that's your neonate. Your neonate. So, management of a neonate, managing HIV, we're going to use AZT, we're going to use 3TC, we're going to use nevirapine. What are we going to give exactly? 10 milligrams per mil. 10 milligrams per mil. 10 milligrams per mil. That's what we're going to give. As soon as this neonate makes 4.44 weeks, and then more than 4 weeks, we change everything. We change everything. More than 4 weeks? Is that all? No, also look at the weight. Is the weight greater than 3 cages? Yes, it is. If it is, then we start with our abacava, 3TC, and then dolutegravir. This is very good. So we're introducing 2 new drugs. Abacava will be able to deal, will be able to deal with that delicate kidney of the neonate. And that is why, abacava is kidney friendly. And that is why we're choosing it. We're worried a little bit about AZT. AZT, it's a very good antiretroviral drug. It's a very good antiretroviral, but we're worried about it because it has got this property or this feature of bone marrow suppression. So we always think about, are we gonna get an anemia here? That's why we were so excited. The baby now has gone over the border of 4 weeks. Now it's 4 or 5, 6, 8. This infant now must get abacava. Well, the kidney is well catered for because there's abacava, 3TC, and then dolutegravir. Well, okay, nevirapine is okay, but nevirapine has got its own problems. So we are excited to introduce dolutegravir because dolutegravir is an integrase inhibitor. It's a powerful drug. You see, HIV, when it enters the cell with 3 enzymes: reverse transcriptase, integrase, and protease enzyme. Integrase is there for the integration of the proviral DNA. Proviral DNA that has been affected or shall I say caused by the use of reverse transcriptase. When you use reverse transcriptase, you actually convert an RNA to become a DNA because the template is from the DNA. We always have this idea of, of the central dogma of molecular genetics that says it is DNA, RNA, protein. So the use of reverse transcriptase is to recognize that, right? So now we have a proviral DNA which has been formed by the fact that the reverse transcriptase has converted the RNA. Which RNA are we talking about here? HIV is actually an RNA. Shall I say the genome of HIV is RNA. So, but we don't like this RNA entering just in the middle. We would like to reverse it to DNA so that it can take the template, for the formation of viral proteins. Right, so that's good. Once you have done that, then the integrase enzyme has got to take over because you've got a proviral DNA already. And then it's got to take over and say, I'm going to take this proviral DNA into the nucleus into what do we have in the nucleus? In the nucleus we have a cellular DNA, and we want the integration of these two. But then we've got a very good drug that intercepts this, that makes sure that this doesn't happen. This doesn't happen. Integrase inhibitor, and that's our dolutegravir. That is why now we have abacavir, TTC, and then dolutegravir. So we're winning now. The proviral DNA is not going to be integrated into the cellular DNA to generate viral proteins. No, that's not going to happen. That's not going to happen. And that is why our baby, our infant is now safe. Is now safe. And this is what we want to do all the time. This is what we want to do all the time. This infant of ours is now safe. And you know, what do? We give them this. We give them this to make sure that the HIV doesn't progress at all. That's one of the best things that has happened. You know, the introduction of this, in fact, the introduction of this dolutegravir, which is an integrase inhibitor. And this is actually very good. It's good for us to know that. And this is the type of thing that I would like people to sort of take. This, I'm speaking now to healthcare workers, the doctor there. I'm speaking now to the nurses there. I'm speaking to the nurses who actually, there are nurses who are actually trained to initiate this treatment. And this is good, man. And I'm speaking also to the caregivers, the parents. They should know what to give. They should know what to give. You're gonna give, if your baby, your infant is more than 4 weeks, then you've started to give your abacavir, your 3TC, and your dolutegravir. And I can tell you that baby is safe. How was the transmission? Remember, you got a birth PCR. That said positive. Do we have to look at the mother? Yes, we have to look at the mother and find out, okay, the mother is HIV infected as well, but what kind of a mother is this? Was she on treatment? Yes, she was on treatment, but she was defaulting treatment. So what is she taking? She's taking TIL-2. TIL-2 is saying to me, this patient was once on first line and now went into second line and even failed second line. So that is why the patient is now taking TIL-2. TIL-1 is for those who have just been initiated, who have never failed any, first line treatment and all that. And we encourage them and counsel them to continue because they are in good shape. They are in good shape. They are taking TIL-1, they are taking tenofovir, they are taking tenofovir, and they are taking 3TC, and they are taking dolutegravir. And they have never failed anything. So they've been good. They've been taking, they've been adherent to therapy. But the TIL-2, it tells us that the patient was not adherent to therapy. In other words, was not taking treatment as supposed to. There's this carelessness of taking it when you like, sometimes you don't take, sometimes. So the patient developed resistance, and so that is why now the patient is on now TILD 2. So there's TILD 1 and TILD 2. So you have to consider that, and you talk to the doctors who are actually busy with adults. And there's something that we do that is, I regard it as being very good. Once a lady falls pregnant, and the lady is HIV infected already, the lady is sent to antenatal clinic. Antenatal clinic, what do? They check. Well, they first of all check. They do what is known as a gene aspect. A gene aspect will check whether the patient is testing positive for the RPOB gene. RPOB gene is to check TB, and TB that is susceptible to rifampicin. And so this is what is being done. This is very good actually, because TB is an opportunistic infection, and the commonest opportunistic infection that we find with HIV-infected patients. So this is what our antenatal clinic will support us with. And this is the type of, and if this is done, if it is done well, then we look at what is known as the CD4 count. If the CD4 count is less than 200, if it is less than 200, we even get worried that is the patient on cotrimoxazole. Cotrimoxazole is your Bactrim. And because we're worried about another opportunistic infection that we find with patients who have a CD4 count of less than 200. And we always worried about the advent of pneumocystis jirovecii pneumonia. These patients, they get that pneumocystis jirovecii pneumonia. In the past, it used to be called pneumocystis carini pneumonia, PCP, carini pneumonia. This is a pneumonia. Pneumonia, first of all, we've got to understand it as pneumonia. Like. The lung has got structures known as the assacs or the alveoli. If there's fluid in the alveoli, then we say the patient has got pneumonia. If there's pus in the alveoli, then we say the patient has got pneumonia. And it is that makes us choose the type of antibiotics to use. For instance, if you have these pyogenic bacteria like Staphylococcus aureus, then we say they are pyogenic because they are pus forming. And so we will, when we're treating the mother, then we will take that into account. We go with drugs or antibiotics which go against these pyogenic bacteria, Staphylococcus aureus, for instance, Troxacelin, for instance. We would look at things like that. And it's important to know that you've got pneumonitis jirovecii pneumonia. If you know you've got that, pneumonitis jirovecii, we know that we have to attack using bacterium or cotrimoxazole. And this is crucial. This is crucially to understand this. You know, the type of bacteria that we have is a determining factor as to what type of treatment are you going to give. Right. I want to say I'm so glad that you had to listen to me today and talking about something as delicate as a PCR that is positive at birth, so that we understand exactly what type of treatment we should get, and of course, which parameters should we look at, like the weight of the patient, because it's a determining factor. It has got to be, if it is 2 kg, and between 2 kg and 3 kg, we know that we're going to give our yes, we're going to give nevarapine, that's for sure, but we're going to use AZT, 3TC, and nevarapine. Those are the drugs that we're going to use between 2 kg and 3 kg. And are we only looking at that? We're also looking at the age. The age, if it is a neonate, is less than 4 weeks, then we will stick to our we'll start with our AZT, 3TC, and nevarapine. And then we know that we give 10 milligrams per mil, 10 milligrams per mil, 10 milligrams per mil. And I can tell you, you'll be looking after those patients very, very well if you do that. And then we know that our transition is 3 kg. If we're looking at weight, our transition is 4 weeks. After 4 weeks, we start thinking of abacavir, we start thinking of 3TC, and we start thinking of dolutegravir. Thank you very much for listening to me. I will come up again with something else, as long as it is HIV related. Thank you very much.